All right, welcome to my case study presentation. This is something I've worked really hard on and I'm excited to share it with everybody. So for my patient selection, I picked a 54-year-old man who hadn't had dental care in 12 years. They brush their teeth 2 to 3 times a week and were a 24-hour-a-day chewing tobacco user. I picked this patient because I believed that their oral health could be improved with NSPT. At their first appointment, they weren't really concerned with anything other than just getting their teeth cleaned. We definitely, by the end, were a little bit more concerned about the broken molars that the patient had. Overall, this patient was definitely healthy. Their blood pressure and all their vitals were within normal ranges, but they were in ASA2 due to tobacco use. The patient did not take any medications or have any existing conditions or systemic diseases. So overall, fairly healthy. These are my pre-treatment photos. As you can see, there's definitely marginal arrhythmia. There's some accelerated recession along these mandibular anteriors, as well as some hyperkeratosis and nicotinic stomatitis from their tobacco use. They had maxillary excitoses and mandibular tori. And this is what we started with. These are some of my tissue statements from our first appointment, which we'll kind of go through all of this stuff, but it's all summarized right here. So these are the pre-treatment photos of disclosing solution. It actually looks like that when this patient does brush their teeth, they do a fairly good job. They had some marginal plaque as well as on the mesial of the maxillary molars, some plaque and some calculus, but overall, when they do brush their teeth, it looks like they do a decent job. They just didn't brush them very often. These are my exam, extraoral, intraoral exam findings. Their submental chain was harder on the left than on the right, which was definitely something to note. They had generalized recession on these mandibular anteriors and 5 millimeters of recession on number 27, and I think it was like 3 or 4 on number 22. As far as their dietary and home care routine, the patient actually ate pretty healthy. They only had 2 to 3 meals a day, no snacks. They didn't have candy very often. They usually drank beverages that were non-karyogenic, except for beer and milk, which they consumed with food. I think the biggest shock here was this patient actually slept with their chew in their mouth. So they would go to bed, and when they woke up in the middle of the night to use the restroom, they would take the chew out and put a fresh chew in and go back to bed. So when I told Dr. Soriano about that, he was absolutely shocked. But they said that they liked to use the regular flavor on one side and the wintergreen on the other side, which was also unique. I had never heard that from a patient before. Looking at their x-rays, the patient has 20 to 30% bone loss and no radiographic furcation involvement, except for maybe 30. Looks like there could be some furcation involvement. They did have 2 areas of decay, 14 distal, 15 mesial, which I was actually able to complete as my DHR surfaces. This is their periodontal chart. They had 21 sites over 4 millimeters deep and 29 bleeding sites on 17 teeth. So it was fun to see the improvement here. I can't wait to show you. Their dental chart, as I stated, I restored number 14 DO and 15 MO. I did 14 DO with amalgam and 15 MO with amalgam and 14 DO with composite. And these are the radiographs that I took after those restorations were completed. The last time I saw the patient, they did still need crowns on 30 and 30. They had broken cusps. The patient was a high risk factor for periodontal disease. due to lack of regular care, heavy tobacco use, and their lack of brushing. They were also a high caries risk due to infrequent fluoride exposure, active caries, visible plaque, etc. I wished that I had another chance to do their initial microscope evaluation because I had the patient rinse with pre-procedural mouthwash literally right before I took the sample. And I also think that my sampling technique was improved at the reevaluation appointment. That said, they were a risk factor of C at the first appointment and D at the reevaluation appointment. Based off of what we saw, I imagine it was probably higher at the first appointment though. Radiographic and periodontal findings, as I pointed out, about 20% to 30% bone loss. Radiographic calculus, BOP, fibrotic tissue fenestrations. They were a stage 2, grade C, stage 2 because of the amount of bone loss, 20 to 30%, stage C or grade C because of the heavy tobacco consumption. This is the Phillips Care periodontal risk assessment, which also agreed they were a high periodontal risk. Agreed that they were a high risk of dental caries. And these are some of the recommendations. A lot of these recommendations we were actually able to complete within our treatment plan. And yeah, I feel confident that both their periodontal risk factors and their caries risk factors are lower now. What hasn't changed, I believe, is their oral pathology risk assessment. They are an extreme risk for especially oral cancer due to their heavy tobacco use. These were their recommendations from Phillips. We did refer, they had a suspicious lesion around number 21, and we did refer that lesion out for an oral surgeon at the last appointment. This is my treatment plan. I definitely improved my treatment plan technique as time went on. But my client-centered goal, or actually the client-centered goal at the first appointment was just to incorporate nightly brushing. They wanted to do that by the time that they came back for their next appointment. So I demonstrated appropriate sulcular brushing using the Bass method. And we talked about how that could improve plaque, inflammation, and calculus deposit. This is their informed consent. We definitely talked about all of the risks of an SPT, including the fact that it might not work. There might be pain, soreness, sensitivity, bleeding, recession, and increased mobility. I just blocked their name out for their privacy. So this is kind of how we implemented our treatment plan. At the first appointment, I was really just trying to complete all the assessments, but I was able to actually scale the maxillary left posterior sextant. Second appointment, scaled the entire mandible. And the third appointment, I scaled the upper right quadrant and the remaining upper left teeth. At the reevaluation appointment, they had gone back to a 1.5 calculus deposit. And so we scaled the entire dentition again. And then I was actually able to see this patient again for their first perio maintenance appointment in the end of April. Specifics for debridement, I used the ultrasonic and hand scaled each area using the appropriate local anesthesia for that area. The patient experienced profound anesthesia with everything that we did. I waited to polish until all of the scaling was complete. So we actually polished at the third appointment and the patient loved that. And that was also when we applied topical fluoride varnish. The instructions I give to all of my NSPT patients are to take an ibuprofen or a Tylenol before the anesthesia wears off. And then I also advise this warm saltwater rinse. The patient never ended up taking any medication, but they did use a saltwater rinse after their second appointment, which was the mandible. And they said it really helped. The tissue responded excellent to treatment. And the patient definitely noticed. They came into each appointment saying like, I can't believe how much better my mouth feels, and how they could tell that the tissues were shrinking and less edematous. And because of this, we actually never made any modifications to the original treatment plan. The patient wasn't motivated by much. They did like how their tissues felt as they were healing, and I think they wanted to continue on with that good feeling. So they actually were pretty good about taking my oral home care advice, but they were never interested in talking about tobacco cessation, stating at one point in time, I'm pretty much done using my teeth anyways. So I didn't really push that issue. We'll talk about it later. Oral hygiene instructions. This is actually probably one of my favorite parts about seeing this patient is you can't take somebody who's not brushing at all and tell them they need to brush twice a day every day and floss twice a day every day and use mouthwash and come in every 3 months. And it's just a lot at first. So at first we just started with brushing every night. And then we were actually able to encourage the patient not to chew overnight after they brush. So they did implement that. The second appointment, I was showing them how plaque had accumulated interproximally, and they were like, how do I get that off? And so we demonstrated flossing technique. And the patient was like, I think I can realistically floss every Wednesday and Sunday. So they started doing that. On the third appointment, I recommended them using their electric toothbrush that they had received. I don't know that they implemented this goal. And then at the reevaluation appointment, demonstrated the use of interdental brushes as an adjunct to flossing. Compliance. The patient was very compliant with oral health instructions, and the tissue response indicated that this was true, and that the plaque was reduced at each visit. So this is my reevaluation chart for their perio score, which I've got a comparison slide coming up soon. But as you can see, in general, there's a lot less bleeding and a lot less pocketing. This is the comparison chart. So as you can see, every number that's green that's on the top is an improvement. The numbers that are red are not improvements. They're all within 1 millimeter. And I think that that could definitely be operator technique. But I think the biggest things to note here are we went from 29 bleeding sites to 14 bleeding sites. We went from 72 areas of 4 to 5 millimeters to 13 areas of 4 to 5 millimeters. And yeah, just generalized improvement. This is an awesome, I think that this comparison perio chart really stands out to me and shows that in fact treatment was effective. These are our post-treatment photos. This is the lesion I was talking about on number 21 that we referred out to the oral surgeon. But as you can see, the marginal arrhythmia is basically all but gone. Even their nicotinic stomatitis or hyperkeratosis is slightly improved. I think that perhaps they're just adding brushing into their routine was helpful with that. Definitely not, the patient never stopped using tobacco, so not completely improved, but we did refer this out to an oral surgeon. I can't remember if I said that. Post-treatment recommendations, we put the patient on a 2-month recall due to how fast they were accumulating calculus. I think that improved home care could definitely reduce the rate at which they are accumulating calculus. And then as far as I know, the patient still needs to get crowns on number 3 and number 30. Reflecting. My treatment plan didn't change much as we progressed. My technique definitely improved. I definitely think I got a lot better at incorporating the patient into the client-centered goal. I think that my charting improved throughout time. Things I could have done different. I could have pushed tobacco cessation harder, but I really didn't want to shame the patient. I wanted them to keep coming back so that we could complete treatment. The other thing, we could have pushed oral home care a little bit harder, but really I was, and this is my greatest learning moment, I was super pleased to see them go from brushing 2 to 3 times a week to brushing 7 times a week, from flossing occasionally to flossing at least like with a point on Wednesdays and Sundays. And this was my favorite. They even asked for an extra floss holder to keep in their car for longer drives because I thought that was a great time to floss. Was stability achieved? Not quite. I think with improved oral home care, stability could have been achieved. Relevance to my education, I think this was absolutely relevant to my education. I kind of wished I had completed NSPT on another patient before I decided to do my case study because I learned a lot. But I think that moving forward with future patients, I think the documentation, especially for NSPT, is really important. Kind of something that I didn't do as well with this patient. It was so gratifying to see the way that the tissue was healing and to really hear that patient, it was almost like they had a glow about them, coming back and showing me and telling me about how they could feel their tissue responding really well to treatment. So I would say that, especially based on the comparison chart, our NSPT was effective. But I will continue to learn and grow throughout my career, and practice makes perfect. These are my references, and thank you very much for watching.